So welcome back to the second part of our lung ultrasound course. If you missed the very first part, don't worry, you will always have access to this lecture and just check your inbox. Now, what are we going to cover in the second part? We're going to look at the anatomy, discuss B-lines, an important topic, and we're also going to see some COVID-19 patients and discuss how lung ultrasound can help us here.
Let's go to the scanner and scan the anterior chest. For scanning the anterior parts of the chest, we switch to a linear transducer, but you also can use a convex transducer. Be always sure to position the transducer on the highest point of the thorax. We start on the right side and initially we have to adapt the depth. So in between 5 to 6 centimeters might be fine. And what you see here is the marker is pointing cranially and you're in between two ribs. So we see rib and rib shadow and rib shadow. And in between the two ribs we see this bright hyperechoic line. This resembles the pleural line. Deeper in the field we see another very hyperechoic line. This is a so-called A-line. This is a normal finding. Be aware to scan the entire anterior chest. Sometimes you see some horizontal artifacts which are normal in a healthy individual. Keep in mind that there shouldn't be too many B-lines. 2 or more B-lines per intercostal space would be considered an interstitial syndrome if it is present in more than one zone. We can divide the chest in 4 zones, zone 1, zone 2, zone 3 and zone 4. Let's review the anatomy we just saw. We see ribs, and ribs always make this shadow here. So you cannot scan through bone. We have a rib cranial and a rib caudal. In between the ribs we have this hyperechoic bright line. This resembles the pleura. We see lung sliding, so somewhat movement of the pleura that is normal, that should be, and we see A-lines. And sometimes we can see B-lines. If there are 1 or 2 B-lines per intercostal space, that's absolutely normal. But what are B-lines actually? B-lines are reverberation artifacts. They always originate at the pleura. They are echodense, so they are hyperechoic. They always move with lung sliding, of course, because they originate directly at the pleura. They do not fade until the end of the screen, and they also extinguish A-lines.
So ultimately, actually, we are imaging artifacts.
Yes, lung ultrasound mostly is about imaging artifacts. Let me show you this example again. Here you see one single B-line, but this B-line shows all the typical findings we can see. It originates at the pleura, it doesn't fade until the end of the screen, it's hyperechoic and it moves with breathing.
Right, and some have also called it searchlights, because in reality, if you look at this image, it truly does look like a searchlight. But Martin, one question that I have, if in pulmonic congestion, you will usually have more water at the base of the lungs, would you also see more B-lines?
Initially, yes. If you have a pulmonary edema, you see it generalized all over the lung. But initially, of course, at the basal parts of the lung, you see more B-lines at the beginning.
So the bottom line is, always check the entire lung to not only determine whether or not B-lines are here, but also determine what the distribution is. Are they generalized or are they localized?
Exactly. Now let's take a look at cardiac imaging. So I was scanning a patient and the lung came in my field of view. At first I was not very happy about it, but then I saw many B-lines. If we take a close look at the heart, the basal parts do seem hyperdynamic, but the apex seems rather akinetic. What would you say?
Yes, this is a very good demonstration of B-lines in a patient where the lung is sliding over the heart or obstructing the view. In essence, we of course try to avoid the lung, but if we see this, it's indicative that there might also be some pulmonic congestion here. We do see that also the lung slides over the heart in patients who have emphysema, but there you would not have the typical B-lines.
Exactly. This specific patient also had severe MR. This patient had cardiogenic pulmonary edema.
How important is a chest X-ray in the diagnosis of pneumonia?
Basically, we use chest X-ray in diagnosing pneumonia, but I want to show you how to do it with lung ultrasound. First, pneumonia, of course, is a very common disease. I bet every one of you treated patients with pneumonia. Of course, we have the history of the patient. They have high fever, dyspnea, they feel terribly sick. We can do a physical exam. We can hear probably final cause crackles at one area of the lung. Maybe we don't hear it. Of course, chest X-ray is used to diagnose it. So what is the role of lung ultrasound? Well, to summarize, the sensitivity and specificity of lung ultrasound is way superior compared to chest X-ray. So it is approximately 90 to 95% of sensitivity and specificity of lung ultrasound compared to chest X-ray, which is approximately about 75%.
But only in the hands of experienced sonographers and ultrasound experts.
Of course, when you have enough experience, you can rule out and rule in pneumonia. You can see consolidations, but of course, they have a wide range of appearances. So you have to see a lot of pneumonias with ultrasound. You can see a pleural effusion as well, and you can follow up if your treatment is successful. So let's take a look. Pneumonias can present in lung ultrasound. Just see like this, a very irregular pleura. And this is small consolidation area as well over here and over here. This is a so-called shred sign. So the lung seems like there is something torn out. But now you might say the consolidation has to reach the chest wall. In fact, 90% actually do. So with lung ultrasound, we can detect all the pathologies that reach the chest wall.
Here's an example of a CT that demonstrates exactly what Martin just said. A patient with COVID-19 infection, pneumonia, and you see that actually the infiltrate is close to the chest wall. So this is definitely a lesion that we can image with the help of ultrasound.
What other appearances can we see in pneumonias? We see a tissue-like pattern, a hepatization. So this pneumonia over here looks almost like the liver. We see mobile air bronchograms, these hyperechoic lesions over here. This is trapped air in this infiltrate. They are called mobile air bronchograms. Why? They move within an expiration. We see a pleural effusion as well. And we also can use color Doppler, power Doppler to visualize vascularization.
But Martin, how can we differentiate between a pneumonia and atelectasis, where you also have dense tissue which might appear as if there's hepatization?
That's a very, very good question. We can differentiate, of course, with the patient's history. Do we have a patient who is terribly sick, or do we have a patient with probably just dyspnea? In pneumonia, of course, we have high fever. In atelectasis, we don't see patients who have high fever. And very important to differentiate is the mobile air bronchogram. In pneumonias, you see the mobile air bronchogram quite frequently, whereas in atelectasis, you probably could see a static air bronchogram, but it's never mobile.
But then we've got the problem of atypical and interstitial pneumonias.
So in atypical or interstitial pneumonias, first of all, we have to know they can be bacterial or viral. What can we see? Can we see them with lung ultrasound? We can be suggestive. We see B-line, and they can have various kinds of distributions. And of course, again, we have to look at our patients. If we see a patient again with high fever who feels terribly sick and we see this B-line distribution, this is suggestive of a pneumonia. But in this circumstance, you can also use chest X-ray, because in interstitial pneumonias, chest X-ray is just better to image.
Now, in reality, we see many of our patients with pneumonias on intensive care units, and there it's sometimes very difficult to perform a thorough exam. They might even have chest bandages and all sorts of difficulties that make it difficult to image the lung. What are some of your tips and tricks?
Basically, there are some really easy tips and tricks to scan those patients. First of all, try to get a view where you see the lung. Like in this case, you see here is pleural effusion, and here you can see lung tissue, and it seems that there is a consolidation. And what you now should do is go as dorsal as possible and then just move cranial until you see the whole extent of the lesion. And if we really go more dorsal and cranial, we see a huge consolidation area over here, so a huge pneumonia on an intensive care unit.
So maybe to summarize, what are some of the very important findings or facts? First of all, the diagnosis alone should never only be made by imaging. You need the clinical information as well. You have to integrate the information with the history and the physical exam, and also look at the lab values, infectious parameters, for example. Use other imaging modalities such as CT and X-ray, even though X-ray probably is losing ground, I would say, to lung ultrasound. Still, these imaging modalities are very, very important when you want to learn lung ultrasound, because it is a means of controlling or checking what you're actually seeing. And finally, use lung ultrasound so that you can monitor patients and to see how they progress or maybe improve with the help of therapy.
Now let's talk about viral infections and lung ultrasound and how we can integrate this knowledge when we scan patients with COVID-19 pneumonia. Let me show you an example of a patient. It's a young patient, coughing, subfebrile temperature, and what do we see in lung ultrasound? We see a normal lung ultrasound. We see here the pleura, we have pleural sliding, here we see a bit of the heart, so this is no consolidation, of course. We see an A line, we see no B lines. Very often in viral infections, you just see a normal lung ultrasound, which is good. So why do we use lung ultrasound in the first place? We use lung ultrasound to rule out a pleural effusion and to rule out pneumonia. Here we see a different case, different patient. We see a complicated effusion and a consolidation over here. Some other findings in viral infections are an irregular or somewhat irregular pleura. It might be a little bit thickened. Also, lung sliding would seem to be a little bit reduced. And we see some reverberation artifacts over here. They are not exactly B lines, but you see that the pleura appears a little bit irregular and a little bit thickened.
But as we've seen in patients with COVID-19 infection, they can develop very severe forms of pneumonia. What is actually happening? What is the pathophysiological substrate here?
What we do have to understand is, as mentioned before, we have millions and hundreds of millions of alveoli. These alveoli have a capillary mesh around them, so approximately 70% of the surface of an alveola is covered by capillaries. What do capillaries do and what do alveoli do? Gas exchange happens. You see CO2 is diffusing into the alveoli and O2 is diffusing into the blood. If we have capillary leakage, as we have it in COVID-19 pneumonia, we have here lots and lots of fluids and protein, and gas exchange cannot happen. The same holds true in ARDS. We have a lot of protein, we probably have some cells, and this leads to hypoxic patients. The patients need ventilation and they need intensive treatment on an ICU.
So what you would see in these patients is they don't have enough oxygen saturation and they cannot breathe away their CO2.
Exactly.
Of course, it's still quite unclear what the clinical picture is and how it is different maybe from ARDS or not. But one thing is clear, these patients benefit if you put them in a prone position. That's what all of our colleagues who are treating these patients now in the intensive care units are telling us. And it is also unclear what role the heart plays, because we do know that viral myocarditis can occur, and it is highly likely that patients with COVID-19 infection could also develop myocarditis. So there are many different factors that come into play when you see these very, very sick patients.
Another principle in ventilation patients with ARDS is that you should use really low tidal volumes. If you use high tidal volumes, all the alveoli, they have stress. We do not want the stress, so use low tidal volumes. Deep sedation or even relaxation might be preferred so that patients do not press against the ventilator. And we have to be very, very careful with the volume status of the patients, because especially in COVID-19 patients, the lungs are like sponges. They suck in all the fluids. So definitely be aware to not overload the patients with volume. To summarize what we can see on lung ultrasound in ARDS, we see anterior subpleural consolidations. There can be various all over the lungs. We see an absence or a reduction in lung sliding. We see sometimes spared areas. So we have on the one side white areas resembling B lines or a confluence of B lines. And on the other side we see normal lung or normal aerated lung. And we see a fragmentation and thickening of the pleura and this diffuse distribution of B lines all over the lung.
But now let's talk about COVID-19 and maybe discuss how this pneumonia is different from other forms of viral pneumonia. Of course, depending on the experience we have so far, which of course still needs to be evaluated in larger studies, but what we can say for sure is that these patients develop with fever, coughs, they develop pneumonia, sometimes very severe forms of pneumonia. They then develop dyspnea, obviously they develop tachypnea and hypoxia, and frequently, at least in the initial phases of the disease, they can develop diarrhea and sometimes taste and olfactorial disorders. So that is how the patients actually present. But what are some of the treatments that we can actually provide to these patients? We discussed a few already previously.
Well, in COVID-19 positive patients, we have to be aware of aerosols. So hygiene is important to be sure that you not get infected as a medical professional. We have to be very careful with ventilation and everything that happens at the respiratory tract of the patients. So if we do have to intubate, we should do a rapid sequence induction. So no intermediate ventilation of the patient during induction. And procedures such as bronchoscopy should only be performed when they are absolutely necessary, and every procedure you perform should happen in really small teams.
When it comes to imaging, we already discussed that CT definitely can help to establish the diagnosis, but it's probably not the frontline or primary diagnostic tool that you should use. Chest X-ray probably doesn't add very much because it has a much lower sensitivity for detecting viral pneumonia than, for example, ultrasound.
We have to be very careful in critically ill patients with COVID-19 about the kidney, so acute kidney injury, and also the myocardial involvement.
And how is the heart involved? Well, the truth is we don't really know very well. There are some small publications and some reports, and of course a lot of anecdotal reports, but in reality we don't know the full scope of problems that occur in such patients. The reason is very simple. We know that there is a high-risk group of patients who have cardiac disease that are affected by severe disease, so we do not know if some of the complications that occur are the result of the primary cardiologic or heart problem, or if it is secondary to the COVID-19 infection. But we do know that patients can have myocardial infarctions. We know that there's been patients described with arrhythmias, and that we also can see myocarditis. And I've been in touch with some colleagues who've mentioned that right heart myocarditis is one big concern.
Let's take a look at two cases Professor Prosch shared in the webinar of Ultrasonography about COVID-19. What can we see in CT scans? We see this so-called ground glass pattern. It's normally localized more towards the chest wall, and it also starts at the lower parts of the chest. Here you can see again this ground glass pattern, here more in the lung, here it is located towards the chest wall. And here's another example where you can see the same findings. It is very important to know that those findings can occur in various diseases of the lung, so they are definitely not specific, but in this pandemic, it's very suggestive for COVID-19 patients.
And now let's turn to lung ultrasound, and of course I must express my big thanks to Lara Venuti and Dr. Baldassare Ferro from Livorno, who provided these images to me from a patient with severe COVID-19 infection. And what you see here, again, you now know, we see these typical B lines that radiate from the pleura, suggesting that there is a lot of fluid in the lungs. So this is the typical finding you would see in such patients.
You also can see that the pleura is a little bit thickened and a little bit irregular, and lung sliding seems to be less compared to a normal patient. If we look at another image, we also see small consolidations over here, and the same findings. We see various B lines, we see a thickened pleura and a reduction in lung sliding. And if we take a look at the last image, it depends on where we scan. We see parts of aerated lung at the right side of the screen over here. Then we see a confluence of B lines and again B lines and a thickened and irregular pleura. And one last image provided by our Italian colleagues. Again, the reduction in lung sliding, the thickened pleural line, and many vertical artifacts. So not only B lines, but very many vertical artifacts, and of course, many B lines as well, and very, very small consolidations along the pleural line.
So I guess with all these examples, especially with these last examples that show how important lung ultrasound is, I do hope that we convinced you to learn ultrasound of the lung. It's not so difficult to learn. It takes some time. Of course, you need practice, but you can really, really make a difference. I want to thank Martin, and I want to thank you out there, especially those who are at the forefront fighting this battle against COVID-19. And again, also for all these people who provided us this background information to make this lecture possible. Thank you.